So at this meeting, we had an update from the ARROW study. For those not familiar with this is a weekly administration of carfilzomib. This is of course very very important because of convenience. The classic carfilzomib schedule is more demanding on patients' time. So what we have learned, what they did is they did a randomization between the standard doses of carfilzomib or an escalation to 20-70 milligrams once a week. The regimen was highly effective. There was no particular signal with toxicity, and in particular with regards to cardiac events. I think many of us were a little bit worried when we had originally seen the data with the Champion study, but in the ARROW study, the results were reassuring. One has to, of course, be mindful in patients who have cardiac history, in patients who may have hypertension, that needs to be very well controlled. But it really provides a framework upon which we can use the weekly carfilzomib. Now, it's very important for the audience to remember the following. First of all, the 20 milligrams should only be used on the first day. So occasionally we see in the practice that, we're all busy, we're running, and it's in our, maybe in our computer, so patients may stay on 20 milligrams. So that's not proper. Number two, it's correct to use it on a weekly basis, but the doses will depend on whether it's used alone or in combination. So in my opinion, without having the full and complete data set to support this, what we're doing is 70 milligrams if you are to use carfilzomib and dexamethasone only, and I use it at 56 milligrams if we use it in combination with an IMiD. The OPTIMISMM study explores the efficacy of the combination of bortezomib with pomalidomide and dexamethasone. And what it really highlights is that pomalidomide will be the go-to backbone for the relapse and refractory schedules and clinical trials. We have alluded to the combination of elotuzumab, pomalidomide, and dexamethasone. There's a study from Moffitt that looked at pomalidomide, cyclophosphamide, and dexamethasone. And now there's one which is bortezomib, pomalidomide, and dexamethasone. I have had the opportunity to previously use this regimen in our clinical practice. And even in patients who have refractory disease to other agents, it has shown a significant level of activity. So if someone has a patient who would be eligible for such combination and would tolerate those two drugs, and in particular no major issues with peripheral neuropathy with prior bortezomib exposure, a clinician should consider that. The Eloquent 3 clinical trial reported on the combination of elotuzumab, pomalidomide, and dexamethasone versus pomalidomide and dexamethasone, and this has also led to the approval of this combination recently by the FDA. Both in levels of response as well as progression-free survival. Pretty much there's a doubling of the times and the level of the response you see with the triplet versus the doublet combination. Now, this highlights once more that we may have to lean quite a bit on the potential aspect of elotuzumab for combinations in relapse and refractory patients. When you look at combinations that have been reported by other groups, including daratumumab, they kind of fall into that ballpark. And elotuzumab is an agent that hasn't had single agent activity but clearly works in combination. There's clear proof of principle based on the previous Eloquent studies. So I'm very curious to see how this pans out. For me, the key question there is whether it can have that efficacy in patients with prior exposure with daratumumab. Newer agents have provided opportunities for the treatment of myeloma that obviously didn't exist before, but have really shown the power of novel mechanism of actions and combinations. For multiple myeloma, the ability to induce these very deep responses was not existent before. And there's some versions of myeloma that will always respond to something. So there's some biology behind how a person may have a complete response, how a person might get into an MRD negative status, even with a simple regimen like RD. But the reality, there's a much bigger layer of therapeutic efficacy. And it is only because of that layer that we have high MRD negativity rates in patients with even relapse and refractory disease, with a regimen, for instance, as the Pollock study, which was a combination of dara, lenalidomide, and dexamethasone. So they have dramatically changed how we think about this. And I think it's fair to say that we already know, even with older agents, that there's a small fraction of myeloma patients that can be cured. I think the fraction is growing. The group from Emory presented data with the not so new agent, so the bortezomib Lendex, followed by transplant. And at 10 years, they reported at this meeting in a poster an overall survival of 77%. For those with standard risk, it was, I believe, closer to 80%, with a curve that looks pretty flat out there. Now, maybe that's an extreme positive result, but even if you were to maybe find some changes in the data and how you would want to analyze it, it really speaks to the ability of very long duration of disease control. And then from a payer perspective, hopefully we can do this with an abbreviated course, maybe transplant, maybe consolidation, limited maintenance, and off you go without any need for future care for multiple myeloma. The unmet need for myeloma is right now at the second relapse. And unmet need is a term that is used, of course, with regulatory purposes, but the reality is that patients that have experienced the benefit of some of those regimens that I alluded to, the daratumumab-based combinations or the carfilzomib-based combination, have very limited options. So there are a number of drugs that will be coming to the forefront, drugs like selinexor, drugs like venetoclax. But when you look at the real-world data, you very quickly realize that the duration of therapy for first line is long, second line, third line, fourth line becomes very short. Now, we're hoping that's going to be prolonged with things such as immunotherapy, and we're just delighted to see there's so much work on CAR T cells and bispecific antibodies. But I would say the second relapse is a problem, because the reality is still the majority of patients go through various relapses, hopefully less so with what I'm saying about cure, but still that's a patient population that is very, very difficult to treat.